Hello, everyone. My name's Jonathan Henry. I'm an emergency physician based in Melbourne, Australia, and I'm coming to you from our PEARLS POCUS Training Collaborative. PEARLS stands for POCUS, that's point of care ultrasound, for emergency and acute care in resource limited settings. And I'm temporarily filling the host spot for the fantastic Bilal Hafiz this week. Um, Quickly, before we start, just about Pearls. We're a training organization or network, and we've held training so far in Tonga, Kiribati, Papua New Guinea, and Vanuatu, where most excitingly, we just returned last week for a second trip teaching the Pearls ED and Pearls Crit Care course. This week, it's my absolute privilege to welcome Dr. Tom Heller. He's a German infectious disease physician who is based in Malawi for the last 7 years. And he's bringing that incredible breadth and depth of experience to us today, speaking on the topic of ultrasound of the liver in the tropical low resource setting. So welcome, Dr. Heller. And look, I heard that you're joining us on a public holiday in Malawi, so it's thank you for that sacrifice. Um, I thought I'd just start by asking,
Thank you for
a
having
lot
me.
of our, it's fantastic to have you. I wanted to first ask because a lot of those on the lecture call today are early on in their ultrasound training journey. So I thought, can you cast your mind back to the early days when you were first picking up a probe, and what's your memory of what really hooked you into this sort of POCUS ethos?
Okay, thank you for that question. That's an interesting one. Well, obviously, I'm already not. I'm already coming towards the end of my career, so I have to page a few pages back. But no, I mean, I think the big thing or the big difference. There is a big difference, and that is the German system. So Germany considered when I started ultrasound, that was in 1995. And at that time, POCUS wasn't really present. It was more ultrasound. There was this point of care element wasn't available. But Germany has traditionally the ultrasound is not really it's not really a radiology tool in the past. It was always done by the clinicians. So the point of care basically, yeah, was always the internal medicine doctor doing most of the scans, and then the gynecologists do theirs, and the pediatricians do theirs, so from that way, it started right away. For me, it started right away to do ultrasound, and I just I mean, I think I enjoyed it just because it is such a. I mean, I think everybody who is here on the call will agree that it's just a great tool to get a lot of information, and even if it is just a funny anecdote, because in the beginning I was scanning everybody just because I wanted to get experience. So I remember this girl coming into young lady coming into the emergency room. She said, "Oh, my breasts are tense," and I said, "Okay, let's go for ultrasound." And my senior colleague said, "What do you want to scan the breasts?" I said, "No, I don't want to scan the breast, but I'm just scanning the abdomen because, it's a nice. She was slim. She looked like not terribly sick. So I thought it's a good can do a quick ultrasound." Well, and then I found the pregnancy, and there was a little bit of there was a little bit of excitement in the ultrasound room. But I think that's the way. I mean, I just scan anybody with any complaint, and I think that's when you learn, because I think the ultrasound is not magic. It's just very simple. The more you do, the more you see. I think that's what I feel, and I can only say I love the emergency people for wrestling the ultrasound probe out of the hand of the radiologists, who have completely different view of everything has to be complicated and things. So I think the point of care approach is much more talking to my way. And of course, here in Africa, then we simply don't. I mean, we have, I think in Malawi, we have two radiologists or so, something like that. So it's not really that the radiologists have the time to sit and scan people. It's not. So it lends itself to be handed over to people who, and usually we have people who have clinical questions. And I think it's a way of thinking. And I will come to, you introduced the FASH protocol, and I had honored to talk to you about the FASH in the past and the TB, but I think we can, it applies. It's a question. The thing is, the clinician needs to find his questions, and then the ultrasound can see what you can answer. But that's, yeah, and I'll talk a little bit about the liver point of care ultrasound program that we designed recently and are now pushing forward. Yeah.
I
So,
love it. Yeah. Look, yeah, I love your slightly subversive attitude, and yeah, hopefully no radiologists are listening into this. But yes, we are
oh, I
very.
mean, I have a lot of good friends who are radiologists, and they mostly agree with me. But then they are maybe not the standard radiologists, are they? Uh, one, one radiologist from England suggested to make me an honorary radiologist. I said, okay, thank you. I take that as a okay.
That sounds.
Maybe we should start.
That's Yeah. Let's start. Look, and yes, Tom Haller, the creator of the FASH exam, back for our second lecture. He's got some bonus content up on our YouTube channel as well. And just a reminder to everyone, keep yourselves on mute. You can put some questions in the chat. At the end of the lecture, we'll stop the recording and then we can have an open, casual Q&A. All right, over to you, Tom.
Yep, let me try to get that sorted here. I share my screen, and this is the screen. Share, and now I just need to go into that mode. Are you seeing my screen in full
Screen looks great.
presentation mode?
Screen looks
Oh,
great.
excellent. Okay, so thank you again, Henry, for Jonathan, for inviting me. And so the topic is well, let me try to stop the video because I'd want, yeah, fine. So the topic today about that I wanted to address is a little bit, or that you asked me to address, and it's a nice topic, ultrasound of the liver in the tropical low resource setting. And when I mean, I'm as you were told, I'm working at the Lighthouse, which is a huge HIV TB clinic predominantly with about 14,000 patients on treatment. And there are some other clinics attached. So overall, we're looking at 60,000 patients. But increasingly the liver becomes relevant to us. And you'll see a little bit why in the course of this session, if it goes first. But first, when I started this presentation, I thought, I mean, you are emergency physicians mostly, I think. So what are actually the problems that we have to pick up the probe in our setting to look at the liver? And I mean, I think that the most four common scenarios are that, and I have to say trauma is out. Okay, so give me that one. Trauma is not my topic, or surgical approaches. So the one is that the patient is jaundice and are having high LFTs, and you want to know, is it just a drug reaction, or is it alcohol, or is there something more undergoing in that liver? The second question that we have quite common is that the patient shows up with a palpable, or sometimes palpable, often painful mass in the right upper quadrant, and we are there and say, what shall we do? An increasing problem is, well, it's not an increasing problem, but it's a problem that we increasingly tackle, is that there are patients who are hepatitis surface antigen positive, and obviously that's all hepatitis B lab diagnostics we have in our country. So, and we are asking ourselves, shall we start them on antiviral treatment with tenofovir and 3TC, or especially tenofovir, or shall we not, because they are just an old infection? And then finally, we have these patients who come with splenomegaly, and we want to know, what is the cause? Is the cause more of a, is it a hematology problem, or is it more of a liver secondary portal hypertension problem? So if you look at these questions then in more detail, then it comes down to these subpoints, and I will not read them all, but I think what is kind of relevant for jaundice patients with high LFTs, is it a cirrhosis or not? And if you have a palpable painful mass, you wonder, is there a tumor? Is it one tumor, many tumors? Is it a liver abscess? Again, on this TDF thing, is the main question is it a cirrhosis? Is it a hepatocellular carcinoma? And when you have splenomegaly, then the main question again is it cirrhosis? Is it schistosomiasis? Or are there many maybe enlarged lymph nodes which point you more towards a lymphoma or hematological disease? So this is basically where I feel our questions are. And that's what I said in the beginning, that you need to define your questions. I don't know, they might be quite different in the Pacific, but probably they are similar. Let me start with a few. Let me start with a problem of the mass, and particularly the painful mass. And that is one of the, I would say, one of the easy ones where ultrasound lends itself to look at the liver. And that's the main point for me is amoebic abscesses around. That's particularly prevalent in resource limited / tropical settings where infection prevention and hygiene is less. And we have quite a few patients that are infected with amoeba and amoeba histolytica. And around 8% of these develop hepatic abscesses. It's more common in adults than in children. Don't ask me why. It's more common in men than in women. Don't ask me why again. That is what the literature says. What we know from animal studies is that necrosis is induced after 5 to 7 days. So after the amoeba are transferred from the bowel into the liver. So it's a pretty abrupt and acute disease usually in a previously more or less healthy individual, because the amoeba in the bowel do not really disturb us. So what characterizes the amoebic abscess if you scan the liver? Well, most of the patients, it's a single lesion because, well, one amoeba made her way through, and they end up at the same point, but it can also be multiple, 2, 3. The frequency is more in the right lobe, and you will see that in almost every liver disease if you read the books on liver ultrasound, you'll find most of the diseases are more frequent in the right liver lobe. I guess it's simply the fact that the right liver lobe is probably 3 times the size of the left. So it's more of common sense that things happen there. And the location is more in the posterior segment of that right lobe. What it causes clinically is often this elevated hemidiaphragm. So that's what you might see in the X-ray. And that might trigger an ultrasound, because it could, of course, also be a subpulmonary effusion or something else that is pushing up here. So you might actually start your ultrasound with a question: is there fluid on that side? What will you see? You will see an hypoechoic roundish lesion, which is high, well, as I said, hypo to partially anechoic. There is no proper wall. So if you see a wall, you have to think that that is unlikely to be amoebic abscess, because that is more like then cystic diseases, echinococcal disease might play a role here, but I think that's not very frequent in your part of the world, as far as I know. I've never been there. But this no proper wall echoes. It's almost a little bit fuzzy, because remember the amoebic abscess is basically a necrotic area that is caused by amoeba eating up the liver tissue. So if you look at that in a video clip, here you see the liver, and here you see that they are not always single, because you see 2 lesions. This is the kidney, but then there's one abscess here next to it. So this is a patient I recorded a while ago. That's why the video is quite old and bad. To do a more newer one. But you see the liver, and then you see this hypoechoic. And the main question is clinical. Is it a previously healthy person? Is it a man? And is he in the right epidemiological settings? So what you can do then to sustain your diagnosis, obviously, you can aspirate, and you see here that here you see the needle coming into the abscess, and when you aspirate that, which ultrasound guidance is perfect for that, you get this anchovy paste. Well, it's basically like liquid liver tissue, and that's the typical presentation compared to the pus, which you might see in bacterial abscess. I wrote on this slide that aspiration is possible but rarely indicated, because you can do hemagglutinin titers and they are almost invariably positive, but that depends on where you are. So in Malawi, we cannot do that. We don't have the microbiology to do that. If you send these to the lab and you say, please look for amoeba, that will definitely annoy your lab tech because they have to really search terribly long until to possibly find a few. The main thing that we do is we send it to the lab and say, push it into a bacterial culture, and we treat the amoeba anyway. So in a way, we just monitor for the alternative diagnosis. What is often, of course, useful is that you scan the abscesses in the over time, and then you can see how they develop, and that can help you to sustain that your diagnosis was right. Then don't be disappointed. Amoebic abscesses get hypoechoic, and they get smaller with metronidazole treatment, but it's not really quick. So don't expect them to melt away and disappear. The clinical response is, even if it is right, they are mostly getting more hypoechoic, but that they get smaller can take weeks and even months until they disappear. And some of them even stay for, and that's approximately 7 to 10%. They stay, yeah, permanently. They have this residual. It's called post amoebic liver abscess lesions. They stay, and they're just normally hypoechoic or partially hyperechoic, and there are some observed for up to 13 years. But they are not active anymore. The clinical improvement is obviously quite a different story. So you give the metronidazole and you see the improvement within days. Good. What's the alternative? The alternative, and also pretty frequent, or probably in Europe, more frequent findings, definitely more frequent finding we have is pyogenic abscesses. And they are mainly caused by gram-negative bacteria. They usually have a slower onset of disease, and mostly the patients are older. They often have other infections like cholangitis or diverticulitis or abdominal trauma, and so they are a little bit different. Also, I have to say that does not 100% apply, because I don't know if you have that problem, that we increasingly see Klebsiella abscesses of the liver in healthy or a little bit diabetes patients, particularly from Asia, and also from Asia mainly, but also from Africa. I remember a Nigerian patient who I recently saw with Klebsiella. It's a mucoid strain of Klebsiella. So what does the pyogenic liver abscess look like? They are more variable in shape and size. They often have irregular walls. They are maybe anechoic to slightly echogenic, but the majority is also hypoechoic. What you can sometimes have is marked echogenicity if there is gas bubbles forming. And again, you can do needle aspiration for the diagnosis. So here is two examples of hepatic pyogenic abscesses. Here you see one which I could easily sell as a amoebic abscess, right? I mean, it looks morphologically not different from the ones I showed you before. It's dorsal in the right lobe. This is now after aspirating. Let's stop that. This is one which is more typically pyogenic, or even by morphology. You see it has this lens map kind of geographic area with tiny little white echoes, which are likely gas bubbles. This is before aspiration now. So obviously you get gas bubbles in anything once you have aspirated and your syringe has put some air in. So, and you see these dirty shadows at the backside of the gas bubbles. So this is a typical pyogenic abscess in an old lady with a cholangitis. Should we puncture? And well, this is it's a very old paper, but I think it is still true, and it's and also Enrico Brunetti is a good friend from Italy who did it. So I wanted to include it. If you compare pus culture versus blood culture, you see that it's much more sensitive and have a higher yield if you do pus. And what you also see is that often in the pus you have polymicrobial infection, whereas if you do a blood culture, you'll find only one. If it makes a big difference, I don't know, but I think if you can, aspirate. And additionally, what you can do is when you aspirate, aspirate as much as you can. The less pus is there, the better it is. And then the antibiotic can often do the rest. Yeah, this is just a little, I think I mentioned that, the little pearl. Amoebic abscess usually do not contain gas unless you have inserted something. So if you see gas in your abscess, then think more of bacterial. Good. I think we have covered this first part. Maybe, well, shall I go? Oh, let me go on for a little bit more. So this is a patient whom I saw, in ultrasound training in Laos. Um, um, and I think she was a 55, 60-year-old lady, slightly obese, with a diabetes mellitus, working in the rice paddies. And what we saw in her liver, she came with fever and yeah, constitutional symptoms, night sweat. So question was TB, but also in the liver, you saw this a little bit like budding hypoechoic, multiple tiny but clustered together hypoechoic to almost anechoic lesions. And that actually is a pretty typical picture. And I think that, at least for Australia, I can say you have the problem. That is melioidosis. And of course, the cause, as you might know, is Brucholderia pseudomallei, mainly water-loving germ transmitted through soil and being in the water, also through dust if you nebulize it. Incubation period is pretty short, and you can diagnose it by culture. Again, in Laos, the culture possibilities are very, very limited. And it makes a big difference because the standard Laotian way of treating an infection is the same like here in Malawi. You give ceftriaxone, 2 grams for once a day for a couple of days, and then hopefully it gets better. If you have melioidosis, you need to treat with ceftazidime, which is pretty expensive. You give 3 times a day, 2 grams, which is a hefty dose, much higher than what we usually give ceftazidime, and we follow it by Bactrim for 20 weeks. So that's this regimen costed in Laos a couple of years ago about $100. So that is something you don't want to throw just because you feel that this is melioidosis, but you want to keep it for patients where you have, well, some underlying evidence. And this is the evidence. It's a little bit better to see in the CT scan. It's this, again, it's called honeycomb pattern, or here in this, if they get bigger, it's called a necklace sign. You see this it's like chambers of pus that are clustered together, and that you can see here's in the solid organs. Here's a second example from a patient. That time it's in the spleen, but it doesn't really matter. It explains the point. You see these, not so many here, maybe 5, 6, 7 clustered together and then breaching out abscesses in the liver or in the spleen. So that if you see that pattern, you want to think, and you have exposure to water, then think of melioidosis in particular. Good. Additionally, we have a few other things we need to mention. I'll not go into much detail, but I want to mention them at least. There is fungal abscesses, which you can see here in an HIV patient. And the fungal abscesses, they often have this wheel in a wheel appearance. So that's a typical thing. They are often not that big. This is a big one, but this is a more typical one. They are smaller ones, have a central echogenicity here, and then this inflammation around. So, and here you have even the feeling you can see the growing fungus ball inside. So that is a fungal abscess, particularly common in patients who have who are immune compromised. Hematology patients, for example, are a good one. HIV possible, but maybe less so. Then, of course, what we have, and that's my standard topic of there are mycobacterial liver abscesses. So there is this is a TB abscess, and it has basically no different appearance than another abscess. So what you can do here is, if it is superficial enough, this one might be possible. You can aspirate, and if you do not aspirate pus, then sample a little bit and put it in the gene expert for TB. That can be positive if that is a suspicion. And also, of course, Mycobacterium avium in our HIV patients, we see that quite a bit. Unfortunately, we are rarely in the position to diagnose it because we don't have tests here in the country. Good. These are the focal lesions. Shall we maybe I don't know how the idea. Should I stop maybe a minute and allow for questions, or what is your
Yeah,
thought?
absolutely. And anyone could speak up for questions. Otherwise, we can leave them till the end. If anyone's got any questions, go ahead.
Cool. No, if there's no questions yet, then let's go on. Now, that was more on the focal infections. Now we want to talk a little bit more of the diffuse infections. And the one that I mentioned in the beginning is the hepatosplenic schistosomiasis. I mean, obviously there's also urinary tract schistosomiasis, but that's a different topic. But the schistosoma, for us, Manzoni, for you, it's probably schistosoma japonicum and Mekonghi, that cause this liver, this chronic liver infections, and particularly what drives the infection is these eggs which are translocated into the liver, into the portal vein from the bowels, and then they cause this inflammatory and then secondarily fibrotic changes, which is also called the Simmers pipestem fibrosis, and you can see that here, which increases the connective tissue, which is more or less white in the anatomy and also in the ultrasound around the portal branches. And the WHO long time had this classification. Honestly speaking, I find it difficult sometimes. So there is a normal liver, that one I can give. There is a starry sky, which is very, very subjective if you feel this is starry sky, or whether the rings and pipe stems are very minimal. So B and C is very difficult to distinguish, and that has also been shown that it is difficult. It gets more interesting when we come to D, when it really becomes substantial, branching out patches going into the liver tissue, and then even this bird's claw image where it reaches up to the surface. That is pretty pathognomonic and easy to see. So the early things you can, a lot of people who come to the tropics, they imagine them because they want to say, oh, I scanned schistosomiasis, but it's often then just a little bit, increased echogenicity. If you see the Asian forms, they have also this, particularly Japonicum, they have this mesh-like. There is the coarse mesh and the fine mesh, which is unclear why they do that, but anyway, they do it. And I'll show you an example in a second. So this is a patient from here, and you see that this is the liver, and you see that there is simply too much white around. And this is not something where you say, is it or is it not? This is substantial. So I think this is without doubt that this is schistosomiasis, because there is simply significantly more white around. Or here is another patient. You see there is ascites, so there is already portal hypertension. There is also quite a big portal vein here, and you see this fibrotic patches and in the liver tissue, which cause the portal hypertension. Yeah, just a word, that one I looked up for you because I have no personal experience outside this lady from the Philippines. Oops, is it running or not? Oops, come on. So this is the mesh that you see in schistosoma japonicum, and it is quite common. So it is 85% from the literature of schistosoma japonicum cases have this pattern, and they may, while the portal changes may get better with treatment, these network pattern usually persists. In Cambodia, they did a survey on schistosoma Mekonghi patients, and they seem not to have this pattern. So it's really a Japonicum trademark, I would say. Schistosoma, that's the Japonicum trademark. Good. What does that matter? I mean, does it matter? Well, obviously it matters because it gives you help with your differential. Because as I said, if you have somebody with a splenomegaly and you're investigating that, then you might go for bone marrow, you might go for this, for that. if you find the schistosomiasis, then you have an explanation. So it helps you in that sense. But additionally, what helps you is that it of course it gives you an idea about the risk of hematemesis. So if you have this higher grade ENF, which I think are the ones that are easy to recognize, then you have it might make sense to send the patient for if there's a possibility to rubber banding to prevent bleeding. And also, if you look at the portal vein diameter, and they are somewhere, this is in meter per meter body height, roughly you can say 17 millimeters or 16, 17 millimeters wide portal vein, you are going with increasing risk of bleeding. And so that are two of the thresholds or two of the findings which would trigger me to say, let's go for a gastroscopy if rubber bands are available. Okay, but now let us look at the elephant in the room. And before we look at the elephant, I have to give you a little bit of an idea what it is. It's hepatitis B, and viral hepatitis causes huge number of deaths annually. And that is as high as TB and even higher than HIV. The majority of that is due to chronic hepatitis, and the majority of the chronic hepatitis is again due to hepatitis B. So as we are increasingly vaccinating, even here in Malawi and worldwide, the hepatitis B surface antigen prevalence has decreased, especially in children under 5 years. So if we just hold our breath for the next 30 years, then probably the hepatitis B problem is gone. But if you can't hold your breath that long, or if you want to do something in between, then you need to think about hepatitis B. And I was looking, well, what's the problem of these guys there in the Pacific of hepatitis B? And of course, it's always good to compare it to your own problem. So here in Malawi, we have about 1,000. Then hepatitis B incidence rate. That's the only thing I found, of about 1,680 cases per year in 2019. And then I looked it up. It's really difficult to see even the color of your small islands. So Samoa, 1,676, Solomon Islands, 1,400, Tuvalu, 1,700, 1,800, Vanuatu, 1,500. So it seems your elephant is as big as our elephant here. And so this might be a relevant topic then for you as well. So what are the common clinical features of chronic hepatitis B? And they are often none. I mean, often people don't know that they have chronic hepatitis B. They might have an intermittent jaundice or mild symptoms, but frankly speaking, in our setting, and I guess it's similar in yours, these are also nicely subsumized under, oh, this malaria, give them a little bit of malaria treatment, and then they get somehow better, and then we assume it was malaria. But nevertheless, there is in some patients constant minimal inflammation of the liver, and this chronic inflammation causes fibrosis in the long run, and then cirrhosis, and because of the oncogenic potential of hepatitis B virus, also hepatocellular carcinoma. But what we see often is that we have jaundice patients who come to the hospital, they get an hepatitis B surface antigen test, and then they're found positive. And then they are sent to us saying, well, this is a hepatitis B, because he's jaundice and he has hepatitis B surface antigen positive. And of course, that conclusion is not quite right. So what we want to find out whether this jaundice is due, and whether there is some liver disease which is requiring our intervention, as I said, with tenofovir mainly. And if you have only very limited resources, then probably the best way to go forward is the APRI score, which is basically the AST. It only requires you to have an AST and a platelet count. There is also a newer score now, the HepsaNet score, which requires you an AST, an ALT, and a platelet count. But let's say it's pretty similar. And our national guidelines, which were just released last year, they rely heavily on this APRI score, but they also rely on clinical signs, which are very rare, and then on ultrasound, ascites, nodular surface, coarse texture, scarce vessels. And that's what I want to talk about in the next few slides, because that are the signs of cirrhosis. And cirrhosis, ultrasound made easy. What do we need to look for? And the first thing is that you need to remember, you cannot rule out cirrhosis. And early cirrhosis you cannot see in ultrasound. But a marked cirrhosis is not very, it's in my opinion not very difficult to find if you know what to look for. And you want to remember these four. There is the surface of the liver, the vessels in the liver, the ecotexture of the liver tissue, and then the segments, and that's particularly the caudate lobe. Let's look at the surface. This is a normal liver, and you see there is a smooth, straight line. That is how a liver should look. Not too much alcohol here. And then you have this liver, and that is more nodular, irregular, bumpy. And you can see that that is signs of a cirrhotic, that are signs of a cirrhotic liver. Here is a moving example. You see there is a bit of ascites that often helps, and you see here these irregularities in the surface, which show you already that this might be cirrhotic liver. And you see inside the liver, we'll come back to that, I just pointed out in the next one. So that's the surface, one of the good points. Then we have the vessels. So what happens with the vessels is that simply because this liver tissue gets more and more rigid and more nodular, the vessels have to move their way around. So you can see that they are a little bit tortuous. They are curvy vessels. Here it's even nicer. You can imagine how this vessel needs to go around the regenerative liver tissue nodules. And overall, the vessels become scarce. So there is almost too few vessels in the periphery. What, of course, gets big is the central portal, because we talked about portal hypertension. But then it's a little bit like a prune tree, you know, when you have this fine twigs branching out. Let me see if I can show you an example. Here is first an example of this curvy, meandering vessels. Here is a long stretch that you can see the nodules that it has to circumnavigate. And then here we have the other problem. You see that the central portal vein is quite substantial, but then in the periphery, these are only the twigs. So this is what we call the amputated portal branches. So that are signs of cirrhosis. I mentioned that before. This is now when I looked at it from the schistosomiasis side, but we can look at it from the liver, from the cirrhosis side. Esophageal varices around 17 millimeters. That's where you have a sonographic indication that there might be risk. But don't do the reverse. So don't say if somebody has below 17, there is no risk. That's not what holds. But if you have above 17, because some people have a high pressure without the portal vein dilating, but it's more. But if you see it, then it is a good sign to go for endoscopy. So the liver texture is a tiny little bit difficult, and that's you need to pay attention to the liver texture. This is the smooth one. It's a little bit like I always compare it to velvety surface, and when you come into the cirrhotic area, cirrhotic liver tissue, it's more like coarse and mottled. And some people describe it as salt and pepper, which I find interesting because it's more like peppercorns and big salt crystals. So it's more rough, more irregular. And if you have seen a few, it is not that difficult. And that irregularity, of course, is reflecting. You can find it with a linear, you can find it with a convex probe. It's reflecting these nodular surface, which you see here on the anatomical cut, and that is simply the regenerative nodules and the fibrotic tissue which surrounds it. Okay, let's see also here an example. I'm not so sure if this transmits well, but this is again a cirrhotic liver, hepatitis B, and you see also, I don't know if you can see the mottledness in the Zoom transmission. But additionally, what you see is I have a big chunk of liver which I see, and I see hardly any vessel except the central vessel down here, right? So that also gives you an idea. And the beauty, or not beauty, but for the ultrasound, for the sonographers, the beauty is that hepatitis B causes macronodular cirrhosis. So that is good for us because it's easier to see than the micro. And then last but not least, the caudate lobe that has a particularly vascular connection, and what happens in cirrhosis is that the right lobe shrinks and the left lobe increases relatively, and the caudate lobe also increases. That was known long ago by radiographers and radiologists. And they measured this here, but it's a bit complicated. What we use is what we call the shark view. It's just a longitudinal view in the upper epigastric, and that looks a little bit like a shark. The eye and the mandible. If you can't see the shark, that's it. And if the shark looks like a decent, nice shark, then it's probably the caudate lobe, which is this area down here. The mandible of the shark is probably normal in size. If your shark has a bit of a face anomaly, then it is likely, or in this one, again, you see this is not a proper nice shark anymore. It has an increased mandible. So that is a caudate lobe increased in size. Good. Now, just a case, maybe how are we getting on time? 5 minutes more, maybe. So just a case to give you an idea. This is the 24-year-old HIV negative man, came to our clinic, started TB treatment a month ago for pulmonary TB, recently started vomiting, and his family realized that he had developed increasingly yellow eyes, jaundice. Liver was slightly enlarged, spleen palpably enlarged, patient admitted to drinking 5 to 6 beers, so reality is probably somewhere between 10 and 12. And the HIV test was negative, hepatitis B positive. And if you look at this liver, you will easily see here's the kidney, and here is the surface with a tiny bit of ascites that is nodular, right? And here is the subcostal view, and you see again these vessels meandering and the vessels, yeah, so this is clearly a cirrhosis. Well, what did we do? We obviously we talked to him that the beers should be maybe reduced or stopped. We couldn't. We started him on hepatitis B treatment because, well, we can't. It is one possible explanation hitting his liver, and thirdly, we put the TB treatment to a liver sparing regimen. Good. Now, just a final word on the hepatocellular carcinoma, which you might encounter, particularly in hepatitis B patients. They are usually, when they are small, they are hypoechoic focal lesions. But we, in our place, we mainly see them when they are big, 10, 12 centimeters. And then they have this mosaic echogenic pattern, often with a peripheral halo, hypoechoic around. And they can be multiple seedings. And what they like to do is they like to invade the portal veins. So this is a patient who was referred to me for TB assessment because he had cough and always right lower thoracic pain. But then when you see already here that there is a tumor bulging out, and when I scanned him, this is the tumor, and obviously that is more than 12 centimeter, and you see this mosaic thing. You see the halo sign here, and that is in a hepatitis B positive patient. A single tumor is very likely to be a hepatocellular carcinoma. We didn't biopsy because it had no consequence. It's palliative care in our setting, unfortunately, and hepatitis B. Well, as I said, tumor intruding into the portal vein, you can see that here. That is a tumor protruding into the portal vein and causing then, of course, portal thrombosis. That's typical HCC behavior. The alternative primary liver tumor, the cholangiocarcinoma, they invade more the bile ducts. Good, and of course, if you have a single large tumor, you may think of primary liver tumor. If you have multiple tumors throughout the liver in different stages or sizes, then of course you think more secondary metastasis, like from a colonic cancer or breast cancer or whatever. Good, and I think here, I will come here quite quickly. What we did now, this one we can leave. What we did now is we put together a push ultrasound protocol using 3 views. So that it is the shark view, the epigastric longitudinal, then the subcostal transverse, and the transcostal view. And we look mainly at the 4 things. We look at is the liver surface nodular, what is the caudate lobe, what is the echo texture, and what are the portal vessels? Are they reduced, tortuous, or curvy? And with that one, we can at least identify quite a few patients who need TDF treatment when they are hepatitis B surface antigen positive. And yeah, and most so these are some of our experience. It was recently published, and I'm happy to share the publication. So 25% of patients had all 4 findings, 19 had 2 or 3 findings. Probably the caudate lobe is the least relevant, but the shark is nice, so we kept it. So and then HCC is also quite common, and ascites is another sign. So I think that ends it. So if you hear hoofbeats, it's more likely to be a horse than a zebra, unless you are in the Serengeti. So this is my standard mention, that you need to know your own epidemiology or your local epidemiology, and that then you need to plan what you look for. Okay. Thank you. I have another case, but we can easily stop there.
We might have a couple minutes more for a case if you like, Tom.
Yeah. Okay. Cool. In this case, let me go back to the case, but that is more of a liver case starting in the lung. So this was recently a 23-year-old male referred for HIV testing, and saw at the clinic, and he was HIV negative. So, but then he was complaining of fever, weight loss, dry cough, hiccups. So the clinicians felt like, oh, this could be TB, and so they sent him for a chest X-ray. And I found them in our daycare room, and they were looking at this X-ray and saying, is this TB or not TB? TB or not TB? The usual question. So you can see the vitals and examination more or less normal. And here you see it's a little bit of a patchy, dirty pattern. But is it TB? Is that enough? So we said, okay, if we don't know, let's look at the ultrasound. And the main finding is this. The main finding that we realized, this is the liver and this is the kidney. And if you compare liver and kidney tissue, then you see that this is a very echogenic liver. That is and that is the bright liver. And bright livers are not, they have a differential. I mean, we see them a lot in Europe, and probably you'll see them a lot in Australia, because they are a sign of metabolic, what is it called now? The fatty infiltration of the liver. But that is in a very slim Malawian looking, that there is another explanation for a bright liver. And that we did the LFTs, and you see that he has a strongly suggestive cholangiopathic pattern, right? The cholestatic pattern, sorry for that. Alkaline phosphatase and GGT both high, but the transaminases, AST and ALT normal. So that is, and that actually, the two things together, a bright echo pattern in the liver plus this cholestatic pattern, they are suggestive for granulomatous hepatitis. And granulomatous hepatitis in our setting is, of course, the most likely granuloma forming infection is TB. Can be other things, but TB is for us the most likely. Now we scanned on, and when we looked at the liver with a linear probe, you see this tiny irregularities on the surface of the liver. They are hypoechoic, almost like little bumps. And that actually is a sign of TB peritonitis. So this is luckily not our patient, but this is an autopsy of a patient with this TB peritonitis, and you see this granulomas in the serosa, which are the bumps that we see with our probe. And then finally we scanned the lung, and the lung has this B lines, this interstitial pattern. Sorry for that. With the small nodules, subpleural, tiny nodules, and and that actually reflected then in the CT scan, which we got later. So he was treated for miliary TB and he got better. So that is but what I want to remind you is that this combination of a bright liver, and if you compare it to the kidney plus cholestatic pattern, think of granulomatous hepatitis. Yes, and I think that's all my slides.